Welcome everybody to this very special discussion that it's a privilege for me to be a part of. I have with me Diane Lee and Adam Meakins, and today we will be talking about the SIJ, the clinical reasoning process, assessment and management of such conditions, how it applies to people, and I'm keen to hear from both of them about their thoughts on this. So very excited to have you here. Thank you for joining us. Just by way of quick introduction, Diane, been a clinician for so many years, and I love what you've contributed to the profession. And you work in British Columbia, Canada. You've done research. You've taught others, including me, and you continue to work towards a better profession and building bridges. And Adam, I've met you in person too. I've taken your course on the shoulder, and massive social impact, social media impact, and just a way of cutting through and getting to the heart of certain messages. I was scrolling through your page recently, and I just loved some of these summaries. So fantastic. You work in the NHS as well as private practice. So fantastic to have the both of you on here. And yeah, I'm looking forward to a great discussion.
Well, thanks for facilitating this, Anthony. It's been a long time coming. I wanted to talk to Adam for a long time, and here we are.
Fantastic.
Yep. Thanks, Anthony.
Way of starting this discussion. Diane, can I start with you? What would you define as an SIJ type of problem or condition or issue or dysfunction, or, there's many words there.
There are, and that language in itself is part of our problem, isn't it, in terms of communication. And I think what we've seen evolve over the 45 years I've been in practice is that our understanding of mechanisms and our understanding about the role of the pelvis in function has really evolved and changed. And I think we could all agree that the current main function of the musculoskeletal part of the pelvis is twofold. Number one, it acts as a shock absorber with very little mobility. And I think from my perspective, more importantly, its primary role is to transfer load. And so when we are looking at the clinical application of some of the evidence, the key thing is going to be, how do we identify whether or not what we're asking the person to do in training or in life, when we're restricting what they do, when we're opening it up to anything they can do, how do we know, what tools do we have in our toolbox that measure whether or not what they're doing is, if I could use the word optimal, is good for them, is healthy, is not going to lead them down a road to pain and lack of function. So I think effective load transfer is probably, and when you don't have effective load transfer, all of the different conditions that then arise from it. Because I think what we know from the persistent pain research is that pain is not related to any specific impairment, and that pain is an output. And we can't use either location or behavior of pain to say that indicates one specific impairment or dysfunction.
Thanks, Diane. So, load transfer is important to you. What that means can be discussed, as well as the fact that looking for one singular impairment can be problematic, particularly in a persistent pain presentation. Adam, did you want to share your thoughts on an SIJ condition problem, as well as anything else you wanted to add there?
Yeah, well, I think the first thing I will do is I think we should start off with an agreement, and I agree with Diane to say that I think the terminology and the wording that we use around the SIJ is a problem, and I think sometimes it leads us to have miscommunication and sometimes misdiagnosis as well. So this term impairments or dysfunctions is often, I think, used interchangeably in between SIJ pain. So I think I like to try to determine the difference between, are we talking about impairments and dysfunctions in terms of, so-called joint immobility, or moving too little, moving too much, moving incorrectly, or are we talking about, it's sensitized, it's irritated, and it's painful as a term as a dysfunction? So I would probably say impairments and dysfunctions, I'll be more inclined to be thinking somebody's talking about a joint moving incorrectly, either too much or too little, and an SI joint pain being something that's sensitized and irritated. And when it comes to, causes for that, I think you've got three broad categories of SIJ painful problems. I think we've got pregnancy-related SIJ pelvic problems. I think we've got specific pathologies that affect the joint and the pelvic area, such as spondyloarthropathies and those sort of inflammatory conditions. And then I think we've got this third and probably most common cause of sacroiliac joint problems, what I would class as non-specific sacroiliac joint pain, of which there's probably multiple hypotheses and reasons. And this is where I think there is a lot of discussion and debate and disagreement around the causes and the reasons why people have these sensitized and irritated sacroiliac joints. But there are cases out there of people with very much specific problems with the sacroiliac joint. So I think, that's something that we always have to keep an eye out for. Yeah.
And I suppose that leads into that next part, which is, well, then how do we assess somebody who presents with what they've often been told, or they've looked up and seen that they have an SIJ problem? Adam, I'll flip the order back and forth. Can you tell us about the assessment for the function, of the SIJ?
Yeah, sure. So I think this is an area where I will probably sort of disagree, I think, a lot with Diane, or Diane might tell me otherwise. She disagrees with me. But when it comes to assessment of impairments of a joint moving around the sacroiliac, or the sacroiliac joint moving too much or too little, then I personally don't know of any tests that are either specific enough, accurate enough, or reliable enough to tell us if the pelvic joint is impaired in its functional ability. So I only tend to use tests that tell me if the SIJ is sensitive or painful when it's stressed or compressed or loaded. So when people talk of impairments, they often are talking about, a joint is moving too much, too little. But I think we just have to recognize that our reliability to judge that is very challenging, because we have no real reference point as to what to base that off. Because human movement around a particular area, around a particular joint, is hugely variable from person to person, and even in the same person, from movement to movement and task to task. So there's all this variability that I think sometimes makes our ability to decide whether something is moving too much, too little, or incorrectly really unreliable. And despite, I think, our best efforts to try and, determine this and assess this with the research and clinical experience, I still think we've got very little idea about what is or is not normal or abnormal movement, from things like foot pronation, knee valgus, anterior pelvic tilts. All these so-called movement impairments, are beginning to be seen as just normal variation that occur in a lot of people without any pain or disability. So, yeah, I think, I'm a very much believer of trying to move away from classifying joints and movements as being dysfunctional, impaired, and recognize the variation in our movements are extremely common. And I think actually sometimes we demonize movement variation unfairly, and I think sometimes it's actually a beneficial thing. So yeah, when it comes to SIJ assessments or pelvic assessments, again, I just think just got to be careful about not falling for those fallacies, and just being aware again of the research that says the reliability of being able to detect it moving too much, too little, inaccurately or incorrectly, it just isn't there. So I think we are pretty much stuck with the pain provocation tests, and again, I don't think these are perfect either, because as much as we think, that we are stressing and compressing the sacroiliac joint in isolation, we've got to understand there's other factors and other tissues moving as well as we do them, but I think the best cluster we've still got at the moment, despite its limitations, is the Mark Laslik cluster. And I think, his cluster of tests, which I know he's sort of reassessed and now looks at just the 2 painful provocations out of the 4, with the Galston's not being, I never say that name correctly, by the way. The Galston's torsion test is not essential to be used, because you can get the same sort of likelihood ratio, around 4.5, if you have 2 of the 4 tests without the Galston's test. So I think for me, that's my sort of go-to assessment process for suspected sacroiliac joint pain. I'll shut up now. I've been talking too long. Sorry.
That's quite all right. There's a lot of stuff in there, Adam, and there's a lot I agree with, but there's one fundamental aspect that I don't, and that's the reliability studies. In the sense that the person I have in my back pocket is Joe Abbott, and Joe is a researcher in the UK who has spent the last 5 years of her PhD investigating all things manual methods, and obviously the reliability studies for the sacroiliac joint come up. And there are a lot of problems with the methods in the reliability studies. And there are, in the last systematic review that was published by clerks, and some really good people were involved in this study, they come up with the same conclusion, that we don't have reliability. But again, the letter to the editor following that publication in 2019, it was just full of things that I don't even understand, which is neither, well, I can't speak for Adam, but for myself, I'm not a researcher in the way that I can actually critique the methods and how things are done. You trust that the methods are accurate. They've been peer reviewed. You trust that they've been reviewed well. And so we look at the inclusion criteria, the subjects, and we jump to the conclusions, because man, when I look at statistics, they just go right over my head. And the trap we fall into is that we trust that they're telling us the truth. And in fact, what Jo has discovered in the course of her PhD is that there are a lot of problems with how the methods of the research being done for a number of different reasons. And that's another podcast for you, Anthony, is to have someone on like Jo, who's a researcher that can actually not tear apart, but break down the literature and help us more to understand it. So my whole take on the pelvis is that the pelvis needs to function like a platform, and whether stable is the right word or not, it needs to be able to mitigate and manage and disperse the forces that reach it in all tasks and activities that we do. And I think the form and force closure theories, motor control theories of the integrated model of function that Andre Vleming and I put together in the late 90s still holds true for me today. Because pain does not guide me in terms of how I assess and treat the pelvis. In fact, those tests of Laslitz, and also when you combine it with the active straight leg raise test, for which there's reliability, sensitivity, and specificity for pregnancy-related pelvic girdle pain, and you still have to use your hands in that test. There's manual methods involved in that test as well. Very rarely do I find in my practice 2 out of 4 of those tests positive. And even if they were, there's no indication that it's truly the joint that is causing the peripheral nociception. And if it was, so what? What do I do about it? I don't have a needle that I can inject inside the joint with fluoroscopic guidance that has to be done expertly according to Bent Sturson. That's not a tool in my toolbox. What do I do about this painful SI joint? It doesn't answer the why question for me. So the load transfer test, as Bent Sturson is now calling it, and in 2002, when Barb Hungerford proposed this test, which she called the Stork test, and basically it's just load the pelvis, stand on one leg, and see what happens at the SI joint. And from the hundreds of studies before it by Vleming and Damon and Schneiders and Baruch, and we could go on forever in the mid-90s, all the work that was done looking at what should happen at the joint. What should happen at that joint when you load it is nothing. It should close pack, it should force close, it should stay stable so that forces can go through it. And the problem is when that doesn't happen. So if you have had damage to the ligaments from trauma or birth, which is not common, if you have changes in your motor control, particularly changes in pelvic floor multifidus relationship, that is, from my perspective, the one of the critical patterns and imbalance of that prevents control of the SI joint. That when this happens and you can't effectively transfer load, we get movement at the joint, and it's not about how much. It's not about we're not judging. Is it too much? Is it too little? Is it any? And can we feel it? So in Antwerp in 2019 at the World Congress on Low Back and Pelvic Pain, I was so surprised to see that Bent Sturson had changed his mind about this load transfer test, and that he's using it now pre-surgically to determine who needs surgery, who doesn't, who needs an injection, who doesn't. And I asked him, I went up to him and said, wow, you're actually using the load transfer test. Are you telling me now that you can feel when the SI joint is controlled and when it's not, when it gives way. And he says, no, I can't feel it, Diane, but my physiotherapist can. And I trust them. And I went, and I test them, is what he said. I said, how do you test them? And like you said, Adam, it's the way the pain impacts the motor control. And when he can change the pain in the SI joint or the ligaments and soft tissues around it, the motor control strategy changes. And the physios tell him the load transfer test is negative. So what he admitted is that he hasn't got trained hands enough to feel this. And, you know, the hands in physiotherapists are very much like a violinist. So if you look at the brain mapping of the left hand in a violinist, the brain map for the left hand is huge, whereas the right hand that just does this is not so big. Whereas in a pianist, both hands are well developed. And there hasn't been a study that has looked at brain mapping of the whole hand in physiotherapists who do manual methods, from light touch to listening touch to direct touch, versus a physiotherapist who doesn't train their hands. But the evidence in musicians certainly supports that as your hands develop, you can more reliably start to feel these things. And so Miwako Ishii in Japan has tested this, and her PhD is published in Japanese. So I can only tell you what she tells me. But and it's not just about the tester being better with their hands. There's a certain number of things in the studies that have not been looked at. Number one, what we often see in the reliability studies is that people don't often see what they feel. And I run into this all the time when I'm teaching, where you have two people who disagree on this same test. So what is this test? You're palpating the innominate with one hand, not the PSIS with your thumb. We have 12 intertester reliability studies that have shown that if you do this and you're just feeling for this, you'll be unreliable. And there's many reasons why. And a lot of the answers come from the robotics research when they're building prostheses for the hands. And the thumb is the spatial orientator. It doesn't have the same receptors in it as the palm, as the index and the middle finger. And this is part of sort of Joe's journey as well, in terms of looking at why are people seem to be more reliable when they use their whole hand versus just a digit. So when we change that and we have people getting information from multiple parts of their hand, their reliability, and this is all empirical, Adam, none of it's been tested yet. Well, Joe's tested it, but it's not published yet. Absolutely goes through the roof. And the other thing we found is that if you have something happening in your shoulder girdle, where when you put your arms out like this, you're rotating for whatever reason. I'm not judging that that is a good thing or a bad thing. It just is a thing. And if you are then looking at the pelvis to see where it is in space, and you have one arm that's apparently longer than the other, you will feel that pelvis rotated to the right in every individual that you assess, unless your cranium and your upper neck is rotated to the left, because our nervous system takes in information from what we see, what we feel, our biases, how we stand, how our own body is. We often use interoception to know where somebody else is in relationship to us. And those testers are incredibly unreliable because they see things differently than they feel. So Joe did a study, 256 manual clinicians of multiple different disciplines to test that hypothesis. And when she pulled the data out of the study of the people who had incongruent rotations in themselves, were twisted in themselves, the reliability just went through the roof. So there's going to be some really interesting data that I'm sure people are going to debate and go on with that gives us a better understanding as to why we haven't shown reliability. So again, this speaks to your point, Adam, about we can't just say because the foot is pronated or the hip's anterior, or you've got thoracic rings that are rotated, that that's a problem for someone. But we can develop tests and offer changes or suggestions to how somebody is standing on their foot, placing their knee, changing their hip, changing something. And then we can further test, almost like a Maitland test, do retest.
Thank you, Diane. I'm holding my pen up just to indicate when, when the time, trying to keep the time thing going. There's a lot there to unpack. If I could just quickly summarize what I heard, there's an issue with reliability studies. There's an area to investigate in terms of, well, what if we looked at the baseline, I suppose, for each of the testers in the studies That brings up the question of how do you test that reliably in and of itself. And then, you've emphasized that load transfer is important. You mentioned Sturgeon, as well as being able to feel that something isn't quite right. So am I okay to just summarize that by saying physios can feel a coordination pattern, a motor control change, and perhaps that's what we're feeling, because that's what the load transfer test is, a coordination test, and I do want to hear from Adam as well. So hopefully, there's a lot that you...
One sentence. We can feel the impact of a motor control change.
Yeah.
We can't feel the motor control change, but the impact on what's happening on one side of the pelvis, yes, we can feel.
Yeah, thank you.
Adam? Just say something. I mean, I find that very interesting with regards to the reliability studies about how palpation could be improved with training and improved tactile sensory information in our nervous system. I find all that stuff very, very fascinating, and I no doubt it is a skill that can be trained and adapted and improved, absolutely, but it still doesn't take away from the fact that we are palpating a variable human being in a variable situation. So again, although we may be able to improve our skills of palpation, our ability to be able to interpret what that actually bloody means is still very unreliable, because again, we don't know what is normal or abnormal. We haven't got any reference points. We haven't got any basis to say, if it does move, is that movement too much, too little? Is it okay? Is it wrong? It's based on so many different contextual variables.